Okay. Yes, I got it.
Wonderful.
Hi.
Let us welcome Dr. Paula Robertson, pediatrician. Thank you so much for taking the time. I am going to turn it over to you for you to address all of these topics that sometimes come up with some patients of mine quite often, and even some professionals in terms of diagnosing. So I'm curious to hear what you have to say today.
All right.
Go ahead.
Thank you so much, Donna.
Yourself. You're welcome.
I will. Thank you for having me, and thanks for this initiative. I think this is awesome. I love when we collaborate like this and just get information out there. And I think this is long overdue. So I am, yes, a pediatrician. I kind of wear many hats. So I work mainly in pediatric emergency at Eric Williams Medical Sciences Complex. But my background, actually, I am a pediatrician who's trained with a special interest in some neurodisabilities and particularly epilepsy. And so I have always kind of worked to advocate for groups along those lines. And I learned so much from all of those patients. So as a result, I've often find myself working with families through the diagnostic procedures. And, we were chatting off screen about the fact that one of the biggest frustrations that our families express is sometimes the lateness of diagnoses, being told that they have to wait until their child is 6 or 7. I want to totally debunk that right now. I know you have some other topics on this coming up. But what I was really excited about is that the American Academy of Pediatrics in 2020 came up with some really powerful recommendations about this. So first of all, what they recommend is that your pediatrician should be doing routine developmental screening. So checking to see that your child has all the right milestones definitely at 9, 12, 18, 24 months or 2 years, and 2.5.
Perfect.
And then in addition, that there's something called the MCHAT. It stands for the Modified Checklist for Autism in Toddlers. So it's a screening tool that parents can fill out. So it is in the form of a questionnaire. It doesn't take long. And that should be given to parents at 18 and 24 months. So we're really trying to roll that out more in certainly my private practice to see how we can get parents involved. Because very often when we ask parents, they've known from well before the formal diagnosis. And, it's good to hear the AAP saying that actually, yes, a diagnosis can be made as early, definitely as 2, with signs that can be picked up, for sure at about 18 months. So I'm looking forward to having an earlier acceptance of recognizing these, because as I know you know this. I don't need to tell you that at all. But early therapy definitely helps, and it seems to be the 3-pronged approach that helps the most with families when we have a diagnosis of autism. It's the early intensive behavioral intervention. It's also parent implemented and targeted intervention. So that's things like the Hannon program, which I know you've been pioneering. And the last one, which often gets ignored, is support for parents and caregivers and stress management, because it can be a hugely stressful and difficult and sometimes lonely experience, I think, until you find a community or the right team or tribe around you. Yeah.
Thank you for sharing that. Oh my goodness. All 3 hit the nail on the head, and I'm so glad you started off with that. And actually, with all of the Hannon parents, my previous Hannon parents, we formed a community, Speech on the Spectrum, SOS, our SOS parent community that we've been quite active in. So I agree. That support, that they love reaching out to each other and sharing tips and strategies with each other, and to just keep each other accountable,
No, for
thank you
sure.
for reiterating early intervention and all the research behind it. Thank you.
Yeah.
So let's go ahead with our first question as to, well, sometimes there's an overlap. Could you expand on that some more?
So the thing about autism, I find it a really interesting discussion, because not only can things overlap with autism, but things can often also be confused with autism as well, right? So several conditions can have similar symptoms along the lines of difficulties with social communication, or fixed or repetitive behaviors or narrow interests that we know is associated with young people on the autistic spectrum. So ADHD, for example, which I know we'll talk about a bit more later, hearing difficulties and hearing impairment. So one of the things that I know we'll always routinely do if there's concerns about a child's expressive language is make sure they've had a hearing evaluation. There's some overlap with things like obsessive compulsive disorder, that repetitive pattern, that sort of fixed, narrow attention can appear in that as well. Even things like anxiety and depression have some elements that sometimes can be a little bit confused with autism as well, especially with some of the withdrawal and the difficulty with engaging. As you know, as a sort of small highlight. But the other thing is that in terms of once a diagnosis of autistic spectrum has been actually made and confirmed, in that umbrella, there's several conditions that can overlap. And they can come in, I've kind of got them into four main categories. So the first are medical issues. So that's things that are well recognized, like epilepsy. And we know that about 30% of patients with autism may also have a diagnosis of an epilepsy syndrome as well. GI or gut disorders, and that's a huge one. So for everything from limited eating to intake, to a lot of the discussion around gluten intolerance, nutritional deficiencies, and so on can really be a challenge here. Then there's sleep issues, which is reported can occur anywhere between 44 to 86% of young people living with autism. Irregular sleep, disturbed sleep patterns, difficulty in getting sufficient sleep, so poor sleep hygiene can sometimes be a challenge. And then the second group are developmental. So that's things like language delay, learning difficulties, difficulties with fine motor coordination can often overlap as well. So often we need to look at that. And then the third group is mental health. So very often, as we alluded to earlier, there can be things like anxiety and depression. There's a huge range of the frequency of anxiety disorders in somebody who's living with autism, but studies have said anywhere from 11 to 84%, so a massive range.
That is.
And we've also, sort of mentioned that we can sometimes have repetitive, almost obsessive behaviors that can appear as well. And ADHD can sometimes overlap with autism as well. So we need to look out for those diagnoses. And then the last thing is genetic conditions. So there are certain genetic or inherited conditions where there may be a higher incidence of autism. And two ones actually that are well recognized is a condition known as Fragile X chromosome and tuberous sclerosis, which is an inherited condition that affects your skin as well. So you often end up with very unique birthmarks associated with epilepsy and a higher diagnosis of autism. And that's just a couple of genetic conditions. There's several others as well. So a good pediatrician will often have to screen and look for all of these issues and make sure that we're tackling them if they arise, and we're looking out for the potential for them to appear.
Perfect. Thank you for, categorizing it as well. That really is very helpful. I'll even try to have a little handout for the audience members to be able to have access to that, the way you've broken that up so wonderfully. Thank you.
No worries.
Well, let's move on, because quite often, even within my practice, I often hear parents tell me, well, the doctor said that they don't think it's autism, but he's very hyper, so it must be ADHD, not autism. Can we address that and figure things out there? And it is quite common, isn't it, to have both?
It is. Again, this is another really interesting area. And, I think it's an area that we're now really developing more understanding about. And it is very true. They can often coexist. Studies say that again, there's huge ranges. The reason these ranges are big is often because the studies have been relatively small, or that there's a wide range in the results that they've found out. So it just indicates that actually we need to have more research on this area. Mm-hmm. But the data suggests that anywhere between 30 to 80%, which is quite high, I thought, of people with ASD, my apologies, can also have a diagnosis of ADHD. And they can often coexist, but there's often many shared traits. And so sometimes some of the features of ASD can mask the others. So For instance, some of the behavioral challenges or the difficulties with interaction can also happen in ADHD. So just to clarify, we know that ASD, and I know teaching your group is very well informed. So ASD we know is a neurodevelopmental disorder with deficits in social communication, but also the restrictive and repetitive patterns of behavior and interest. And ADHD is also a neurodevelopmental disorder, but this one is characterized by three main areas: difficulties with attention, impulsive actions, and hyperactivity. Right. So we can see that there are some overlap potentially in things like difficulties with social communication or communication and engagement in particular. And one other interesting discussion is that they may actually, one theory is that for some of our patients, there may be common genetic risk factors, right? Some of those inherited genetic conditions that we spoke about are associated with an increased risk for both ADHD and ASD. So a huge area for potential research later on. So yes, I think it is much more common than we previously thought. I think it's important to have somebody who is trained specifically in screening for both these conditions, basically work with you if you have concerns about this, but know that there may be some overlap both in symptoms and the way that they can present, and then a massive need for further research on the genetics behind it.
Thank you for breaking that down and for comparing the two. That's
absolutely
very helpful.
Yeah, no, not a problem at all. I mean, I'd say the other thing is that generally speaking, although this is a huge generalization, ASD, often the features can present early. So we know that from a lot of parents who, when they think back, they think it from infancy, and babyhood, there were issues maybe with eye contact and reciprocation. Whereas ADHD tends not to necessarily be apparent and formally diagnosed until later. And that may well be because some of the issues actually may present at school with attention. Yeah.
That's when we really see it.
Right. Yeah.
Yes. So that's a good gauge for us to differentiate between the two, you know.
Yeah, that may be another one as well. Mm-hmm.
That's helpful. Good. All right. Well, then, how common is it now that if one family has a child who has been diagnosed, how common is it for if they were to have a sibling follow along?
Yeah, so I have to say this one made me go and look at the research on this one. So I love this question. So amongst all families, it is said that 19% of families in total may have more than one child with autism. But there are some situations where this may be more common. So definitely twins, for example, if you have one twin, especially if you're identical twins with autism, you have a much higher chance of developing autistic traits or being recognized as having autistic traits in your twin sibling. Yeah. So this one was, I actually think, this is a question we often get asked. And I know it's a worry and concern for family members as well.
Yeah. Mm-hmm. Yeah. Mm-hmm. Where sometimes the families will say to me, I don't think we should even have another sibling right now. We shouldn't think about that. We're so nervous because we have to give so much attention. And sometimes what I do notice is the sibling comes along and it is a welcome change for the child in the family whose language is developing, because then this little sibling comes along and has the perfect model of language within the home.
Absolutely.
And sometimes it just brings about so much more, and it's so positive, so yes, you might have a fear, but on the other hand, it could also be a positive thing.
And the benefits go the other way as well. So what we often find and what's been shown is that children who grow up with a neurodiverse sibling, they are much more likely to show elements of compassion and social connectivity in the workplace. So it makes you a better
and perhaps advocate for their sibling and for the special population. Yeah. I love that. Thanks. Yes. Okay. So now we've spoken about the fact that, you've even spoken about sleep disorders, the whole gut topic, GI topic, and ADHD. And of course, the question then comes in, what about medication? Do we medicate for things like this or not? Even epilepsy and the medication, just in general. Let's talk about medication versus non-medication.
Sure. I mean, again, this is a big sort of broad topic. I'd start by saying that currently there's no medication that can cure ASD.
Thank
So
you. Let's make that very clear. How about we say it
yeah,
again then?
there's no medicine that can cure ASD. But there's a whole discussion around ASD generally and neurodiversity. I think it's
That's right.
important for us to recognize, that neurodiversity is necessarily a bad thing. In fact, I think it's important that we recognize things that are features, issues that are different from us. I think as a population, as society, it's important for us to include all. And we do need people who are on all ends of the spectrum for us to advance. So I definitely start with that. But having said that, there are some medications that can treat certain symptoms. So let's look at epilepsy, for example. We said that happens in about 30%. Usually we would say that certainly if you have more than 2 unprovoked seizures, that's usually an indication for thinking about going on to treatment. Anticonvulsant treatments for seizures. And, one of the things we tell parents is starting anticonvulsant seizure medication doesn't always mean it's going to be lifelong. The general rule is we're looking on the least amount of medicines to control the seizures and ideally make you seizure free. But we're aiming for about 2 years of seizure freedom before we potentially can wean medication off. So often it's not unusual to find in young people that they may not always be on medicines for life where epilepsy is concerned. But we may also use medications to treat certain behaviors like self-injury or aggressive behaviors, for instance. That's where you might hear about medications like risperidone coming in, for example. And what I would also advocate for is what the majority of research shows that medications are most effective when they're used in combination with behavioral therapies. So there isn't in this particular situation where maybe our young people are showing some aggressive behaviors, for example, it's also important that you work with your psychologist or your OT, for example, to help teach regulation, emotional regulation, and dealing with big feelings, for example. So just medicines alone isn't just the answer. And we may also find that we may get a space for the role for stimulant medications. So that's things like Concerta, for example, in ADHD, if that's a co-diagnosis, or occasionally anxiety medications or antidepressants, depending on if they're mood disorders. But I would advocate definitely that this would be something that would be part of a multidisciplinary approach. So you got to work together with all your healthcare providers, all the members of your team, your tribe, if you will, right? To ensure that there's safe medication use, because each person actually responds differently. And so you really do need an individual assessment and consultation.
Oh, so critical. The team approach, as well as, monitoring, constant monitoring. And that is, to me, especially for the team approach, and Dr. Robertson, you and I have sat on cases. I mean, I'll never forget our very first case from many, many years ago, right? When we created our whole little team, when Trinidad didn't even consider having that kind of interdisciplinary approach. And we didn't have the resources then, but how far we've come now, right? And yes, especially that regulation piece you spoke about. And I hope that guest speaker, Sasha Windsor, I know she will expand on that some more. But that self-regulation is a big piece as well, that not necessarily, okay, well, pop a pill and they'll self-regulate, but they have to have that understanding. And I like that you use the word for those big feelings. Exactly.
Yeah, no, I think that's a big one I often have to talk about, that actually what I, not just for young people on the spectrum, but generally for children, that it's important for parents to look at the need behind the behavior. What's the reason? What's the need behind it? Because that's what needs to be addressed. I mean, often it's, I do know that sometimes big feelings can be embarrassing for parents to contain, especially in public places. But behind there is often some sort of unexpressed need. Whether that is for reassurance or security, or even if it's things like they're being hungry or tired or sleepy, that may just be worth looking at and exploring. And really what our young people need us to show them is how to regulate, how to be a safe space, and how to deal with those big feelings when they happen, because we all get them.
Correct.
It's just having the toolkit for dealing with them. Yeah.
Yes. You know, it is they're communicating. They're trying to communicate something to us. And yes, indeed, we do need to acknowledge those big feelings. We do need to show some sensitivity and help them recognize that we understand that. So face it, but also model the language around it. Mom, I don't like that.
Yeah.
Mom, it's too loud.
Yeah.
Mom, going to PriceSmart is too much for me right now.
Absolutely. Absolutely. But the thing is, you can't have that conversation in the middle of a big storm of emotion. Right. And so that's the other thing I often have to talk with parents about: connection before correction. So the thing is, when we're having a huge blow up, the issue is then to model what to do, allow that safe space, recognize how they're feeling. And then when we are calm and we're in a safer environment, you can then model what you'd like. And show, rather than perhaps having language that says, don't do this, don't do that, don't do the
Why
others.
are you doing
So
that?
what, right.
No.
Show what you would do. So you just demonstrate nice touch. And show them what nice touch feels like, for instance. Show them what maybe a nice playing would look like, what using your words would look like, for example. So model that for them. You got to do that when they're calm and receptive.
I'm going to highlight that: connection before correction. Ooh, big one. Big one. Thank you. All right. I guess this overlapped with all the questions, previous questions.
I mean, just to reiterate, it can, is a short answer with this, and can autism be confused with other conditions? For sure. And, you know, we kind of touched on some of this already, but because of the features of the autistic spectrum, the kind of difficulties with interaction and social communication that can arise, and that sort of fixed repetitive behaviors, yes, for sure. So things like ADHD, hearing impairment, obsessive compulsive disorders, for instance, even post-traumatic stress disorder and anxiety and depression. And language, not necessarily autism related, but expressive and receptive language difficulties. All of those can potentially be part of your differential diagnosis. So you need to kind of look at all of those as possibilities. Yeah.
Yes, sometimes in speech world, a big one that kind of relates to this is apraxia, which is that motor sequential movement of sounds to produce sounds. And
Donella, for some reason, I've lost your sound.
Still, are you hearing me now?
I've got you now.
Okay.
I heard in the speech world.
In the speech world, the one of the diagnoses, apraxia, or childhood apraxia of speech, is quite common, with motor sequential movement of the way sounds are produced. And that is often one that oftentimes autistic individuals will present with apraxia as well.
Agreed, for sure.
So what about a dual diagnosis of autism and Down syndrome, which I have been faced with? And sometimes I tend to, as a professional, I tend to compartmentalize. And so that's why I brought it up as, you know, a question here, because if he has that genetic disorder of Down syndrome, how could he possibly also have autism? You know, so could you expand on that for us a little?
Yeah, no, I have to tell you, you've done me on some great research for this one. So I found this was a great question as well. It is definitely now appreciated that these two can coexist. A Down syndrome can coexist with autism. Again, a wide range of reported incidents, anywhere between 4 and 41%, right? Part of the issue here, meaning that between 4 and 41% of young people with Down syndrome may also have a diagnosis of autistic spectrum. But part of the challenge here is that some of the tools, the diagnostic tools that are used to identify autism, are not all validated for Down syndrome. So when you look at what are your criteria for using the tool, for instance, some of them have actually said that it hasn't been properly assessed or evaluated in young people who also have Down syndrome. And so that's been one of the challenges in the past. Now, I'm glad to say that seems to be changing. I found that the University of California actually has some really interesting research on this. And they did a meta-analysis of their population of young people with autism and potentially with Down syndrome. So they found a 16% incidence of autism in young people with Down syndrome versus 1.7% incidence of autism in the general population.
Ah.
So for sure, there's a higher incidence in Down syndrome. Interesting stuff that they also found as well was that it seems to be that from the data that they've got, that there may be more of a tendency for autism to be diagnosed in males, in boys with Down syndrome. And there's certain associated conditions that may make it more likely to have a diagnosis of autism. So if you have Down syndrome, for instance, and you have epilepsy, and specifically a type of epilepsy called infantile spasms, that particular group of patients, about 20% of them tend to have autism as well.
Okay.
It also tends to be associated with lower IQ and with a family history of a first-degree relative, interestingly, with either speech difficulties, learning issues, or autism spectrum or autistic traits themselves, right? One of the main issues with this particular group is that age gap in the diagnosis. So we were talking about the fact that often the diagnosis has been made relatively late in the past. Unfortunately, it tends to also happen later in our Down syndrome population. So the age gap between maybe first presentation to medical services and a formal diagnosis of autism has been as long as about, the average is about 5 years. So people have been working a lot to try and close that gap as much as possible.
Oh, good.
Yeah, I think the other challenge is that the way that autism may manifest in Down syndrome may look a little different from what may happen in other populations. So the most common features, according to the University of California group, is that we may see developmental regression, mood and behavior issues. Sometimes things like stereotypical or repeated behaviors, for example, and often as half of them. So that could be repetitive behaviors like staring at fans or lights, for example, or just repeating actions. I've seen a video of one little boy who liked to spin in chairs. Poor eye contact, abnormal play can also happen as well, and impaired social skills. But because I love working with Down syndrome families, because Down syndrome kids are awesome. They're really affectionate and loving, generally. And then what has been found is actually in the group of patients with Down syndrome, they tend to be much more, and autism, they tend to be much more social than patients with autism without Down syndrome. If that makes sense. So sometimes that also makes it a little bit more challenging to make the diagnosis, but for a lovely reason, basically. And then you may get lots of issues with speech and language. So on average, people with Down syndrome and autism tend to acquire speech and language roughly about 6 months later than those without. So definitely receptive speech, expressive language delay, much more likely to occur in this group of patients who have both. Yeah.
Wow, thank you. I guess that's why we tend to compartmentalize. Maybe I'm not the only one. And maybe that's the reason for the later diagnosis, you know, it's because, hold on, this is Down syndrome, this is autism, you know, how could it possibly overlap?
I think it's difficulty, you know, maybe teasing out, yeah. And yeah, overlap's the right word, because I think there is like in this particular group, there is a fair amount of overlap for sure.
Yeah, certainly. Well, okay, this brings us to our last question. So what are the conditions that overlap? I would say characteristics. You know, you just shared on some, in particular to Down syndrome, but even with the OCD and with the other, you know, co-occurring diagnoses, are there any that we perhaps missed out or is there anything you'd like to expand on here?
Yeah, I mean, I think one of the main things that I'd see, you know, from the families that come to us initially, starting the journey and seeking a diagnosis, one of the major common concerns for families definitely around sleep, around some behavior, some challenging behaviors, especially if they're not, necessarily understanding what's behind the behavior, for example. Sensory issues. And, I was really fascinated to learn that actually not all children with autism are sensory avoidant. Some definitely are sensory seekers. And so that often raises issues, in school when the kids who like to lick, for example. And then we may get medical issues around that. So my kids who like to lick or to put things in the mouth, for example, they often can end up with skin conditions, meaning I'll often get them having a little bit of dermatitis or irritation around the mouth from saliva. And so often we have to talk about like oral hygiene and skincare management.
You get brush with something with that?
Yeah, we might sometimes see that as well, or even occasionally bits of impetigo can happen as well. And then that can be an issue. Certainly around nutrition. So if there's a relatively limited diet, sometimes there are nutritional deficiencies that can happen as a result. So I've dealt with kids, for example, who will only eat white food. Food that's white in color, or different textures. So they'll only want foods that are mushy, for example, or maybe not. But the issue then becomes, because we're not necessarily getting a broad range of foods in our diet, maybe screening for nutritional deficiencies like zinc and iron in particular. And if they are detected, supplementing them if we can, basically. So it's thinking about that.
Constipation also comes up.
Right. Oh gosh, yes, that's a huge one too. Yeah. For example, because that's often linked to maybe not getting enough dietary fiber in your diet in particular, and also issues around perhaps the one of the things that your gut needs is a very diverse diet. I usually talk about the whole rainbow of foods. And so if we're limiting that, or perhaps texturally our foods are not particularly bulky, then definitely constipation is a huge one. That's true, for sure. Yeah. So definitely those are some of the issues that we may have to work through with families. I'd say sleep and gut, developmental and behavioral, and then later on perhaps some of the mood disorders, mood issues, especially around anxiety in particular. And I saw this a lot coming out of COVID, because kids really struggled, and not just our neurodiverse kids generally did, but especially our neurodiverse children found that it was really hard to understand what was happening. There's a lot of separation anxiety, a lot of difficulties kind of reintegrating back out into life afterwards. So supporting families through that is definitely a big priority, I think.
Yes, thank you for bringing that up. Even, you saw the effects even with my littles, at one time, it almost felt like the rug was pulled out from under their feet. And their way of expressing it, of course, would be different in that one moment, mom was allowed in the therapy room with me, and the next moment she was not. She had to stay outside in the car, and it just changed my world, and made therapy a not so fun place to go to. That's just one little case with a 2-year-old, far less for everyone else, right? So
no, for sure. We've asked a lot of our young people through the pandemic. And you say, when you think about it, it's the perfect storm for kids to feel anxious, because during the pandemic, essentially there was something invisible and unseen that was dangerous, that was out there. We weren't sure if our loved ones were going to survive. Everything was telling us it was unsafe to get out. And then all of a sudden, you're told, well, okay, it's we're all right to go back out there now. So, and I think we probably, in retrospect, should really have thought about how better to support young people to actually make that transition back out there, and to not see the world as a dangerous place.
Respecting our children as little humans as well, not just brushing them aside. Oh, he's a child, we don't need to explain that. Yes, we actually do.
Yeah, no, for sure, absolutely.
Oh, well. Thank you so much for your time. This has been a wealth of knowledge, I will tell you. And I look forward to any questions that may come in by the attendees. And we'll definitely be reaching out to you to ask you to answer any of those questions that come along. I anticipate quite a few, so we'll see. Thank you so much, Dr. Paula Robertson.
Anytime. Pleasure.